Okay, moving on to our last module now, which is about fullness and heaviness. The causes of fullness and heaviness begin with edema, which we have just talked about, which can also cause skin thickening, but patients will often have a tremendous sense of heaviness in the breast, and this can be due to congestive heart failure, it can be due to radiation therapy, or central causes like venous or lymphatic obstruction, as we saw with skin thickening. Fatty tissue alone can cause heaviness, and obviously lactational change, breasts full of milk are very heavy. And then some patients have pretty dramatic hormonal effects which will cause heaviness. Lastly, implant problems can cause these symptoms. Okay, we already talked about edema, we don't have to go back to that, but let's talk about fatty tissue now. Here's a patient that presented with fullness in both axilla, and you see here that she has very prominent axillary fat pads. Here on spot compression, we see normal nodes, but we see protuberant fat. It's completely loosened, no mass there, and that corresponds to her palpable area of fullness indicated by the triangle there. So axillary fatty tissue causing fullness in the axilla. Lactational change. Here's a 34-year-old who is 8 months pregnant, not quite nursing yet, but the breasts are ready. The breasts undergo a remarkable transformation in the 9 months of pregnancy, leading patients to have frequent complaints of fullness and lumps as they get later on in pregnancy. But sonographically, what we see is this kind of a pattern. We see the fat, and then we see the lobes of breast tissue, which are full of dilated lobules and ducts. These are the TDLUs, the terminal ductal lobular units, which normally are about 2 millimeters in size, but in patients getting ready for lactation, they can be 8 to 10 millimeters and very prominent, but they are scattered in this area of echogenic stroma, the supporting tissues and all the blood vessels bringing in all the nutrients. So these lumpy areas in patients that have fullness due to lactational change look like this. And here we are just under the nipple. We see the lactiferous sinuses here. They're congested already with milk ready to come out here. Typical appearance of lactational change. And here's another highly functioning lobe of breast tissue with the very vascular surrounding tissues reflecting all the nutrients that need to be brought in to make this milk. Okay, so second to last, hormone effect. This is a rather striking change in an 82-year-old on the left. This is before hormonal therapy. She was a Birad's category A, almost entirely fatty. After beginning hormone replacement therapy, she became a Birad's breast composition D, extremely dense. And she was actually uncomfortable with the sense of fullness in the breast and chose to stop taking her hormonal therapy because of that. Okay, lastly, implant problems. Implants can cause a feeling of fullness or tightness, particularly when rupture is involved. Sometimes there is bleeding around the implant or subcapsular hematoma, which is very painful and tight. But ruptures with extruded silicone will cause these symptoms as well. And here you see a little collection of extruded silicone around this implant. On MRI, we will see ruptured implants reflected by what we call the linguini sign, the folded, collapsed shell here in a sea of silicone, and that will cause a feeling of fullness too. Contour change creates a feeling of fullness as well, and on physical exam, such as in this patient where there's a herniation, not a rupture, but a herniation through a weakness in the fibrous capsule that contains the implant. So we see this herniated portion of this double lumen implant causing a contour change and feeling of tightness and fullness in this reconstructed breast. This patient presented with a sense of fullness and tightness. She was a year and a half or so after her reconstruction, after mastectomy. And for a while, her doctor thought that it was typical reaction to having an implant reconstruction, which patients do have, but it kept getting worse rather than better. So she had an MRI, and it shows that there's a lot of enhancement in her pectoral muscle here. And this was, unfortunately, recurrence of tumor in her pectoral muscle on top of the implant rather than just implant changes. Patients who have tissue expanders placed as part of breast reconstruction will also have, obviously, a sense of great fullness and tightness as they are being expanded, but sometimes there are abnormal fluid collections that develop, and our job is to discern whether the fullness and tightness is as expected or whether it's due to an abnormal fluid collection. So here we see sonographically the tissue expander wall, and then we see this fluid collection around it. On the right side, on the left side, it looks like this. Here's the fluid collection around the expander. On the right, we see a little bit more heterogeneous material here. This could be some hematoma or inflamed tissue. The tissue on the left is smoother and thinner. Of course, we cannot determine sterility or infection. The only way to do that for sure is to take a sample of the fluid and culture it, but we can say that one side looks more suspicious than the other. This patient ended up having an aspiration. She had a drainage catheter placed by interventional radiology. Here you see the expander and the drainage catheter placed under fluoroscopy, showing no pneumothorax, but she ended up having no growth of bacteria, so it ended up being a sterile collection. Was it helpful to do the drainage? Probably. If there's an excess amount of fluid, it is more likely to have an infection develop compared with smaller collections. So sometimes drainages are done even if it's not infected.